The first question I would ask the patient is, what bothers you? Why are you here today? Is it because your teeth are not fitting properly? Have you got a functional problem? From an aesthetic point of view, what is your problem? Now, from what we've spoken about this morning, I'm sure we've all now have made a decision. Without now knowing what bothers her, my feeling is that from a frontal point of view, an important thing for me is I'm not sure if she is in repose, total repose. From the frontal point of view, have you got that slide? You got it?
Pardon.
They've got a shift.
Yes.
No, that's this.
No. Ребят, надо переключить еще раз на мой компьютер, простите.
Can you see?
Yeah. It's here. You like a hunter. Red.
Red. Go back. Go back. That's it. Okay. Let's look at the thirds. The lower third certainly looks long. Okay? I don't see an interlabial gap. I'll be very interested to see how much tooth do I see when she opens her mouth. Like that. When she opens her mouth, how much tooth is she showing? Why did I ask that? Because this morning we said, never treat the smile. Because if I've got a feeling that she's slightly pushing her lips together. Slightly. There. Okay? Now, if I look at that picture there, I look at the lip and I see that the bottom of the lip is slightly thinner. So maybe there's a little bit of tension. And we'll see tomorrow when we see the patient how much tooth is she showing. And the problem that I have with this patient is when she smiles, we see, we see maybe 3.5 millimeters of gum. But if I only see 2.5 millimeters of tooth, I cannot move the maxilla up. I can't do it. Because then when she's not smiling, there won't be any teeth. So at this stage, my feeling is that we would do a Leforum 1 osteotomy and maybe go up 1 millimeter, the bone cut, and correct the dental midline. The lower midline, if you look carefully, you'll see the lower dental midline is about 1.5 millimeters to the right. So I would propose that we do a unilateral sage on one side to correct the mandibular dental midline in the middle of the face, then do Lefour 1 osteotomy, get the dental midlines corrected. If there's a slight vertical correction, we'll do that. The rest of the vertical correction we do with the mandible. We do a genioplasty, shortening the mandible, the chin, and slightly forward. Let's look at the profile. You see, she can do, now I'm not too sure if she's in the repose, but anyhow, we'll go up and slightly forward, not too much because we don't want to make the labiomental fold too deep. Shall we do a video?
Yeah.
Okay. So we do what I suggest and see what happens, because this is what's nice about this.
Переключаем на транслятор.
Where's my
What?
My tracing.
Okay, just a second.
Okay. So, as I suggested, what I like to do, you can see there, is, can you see the nose? Now we know what the nasal bone looks like. It looks like there's a bit of nasal bone there, and then the nose looks like this. Am I right?
Yeah.
So we want to make the cuts as close as possible to the actual surgery that we're going to do. So I said we're going to maybe shorten it a bit, and in this case I would not do much more like this. You don't want to change the nose, so we'll we'll keep the Lafon osteotomy there.
You will perform straight line.
Straight line. The reason for that is we're going to advance the maxilla,
Yes.
so we will definitely address the soft tissue.
Yeah.
But the nasal, we don't want to change the nose too much, and the higher we go with the before one, the more effect we will have on the nose. So I'll make a little compromise for her. Then I'm looking at the mental foramen. There it is. So I'll do an osteotomy here. Okay, and then we do a unilateral sagittal split osteotomy in this area. I look at there's the lingula. So I would draw a line. Why I do this line is just to see if am I doing any changes vertically. Not in this case too much, but I'm just showing you where I like to do it. I can see what I've done to the posterior mandible if I've done some shortening there. So basically this is the cuts that I'm going to make. Now we need to do the cephalometric prediction tracing. Where's that piece of paper? This paper comes all the way from
South Africa.
From South Africa. Don't tell the customs that I've imported press tracing paper. Thank you. Okay, so the first thing we do is we trace in everything that's not going to move. So it's the sella, the skull base, the frontal process, there's nasion, the nasal bones, this part of the nasal bone, this part of the maxilla is going to stay there. I draw in the orbit, and I like to, to make it look more anatomical. It's not cephalometrically important, it's just to draw the zygoma in as well. Just to give me a feel for what it looks like. Here goes the pterygoid fissure. And I would draw in the stencil, yeah. I would draw in porion. And I would draw in my maxillary osteotomy cut. Okay? And now, remember what I said this morning, incisor position. The upper jaw incisor position. So I want to, let's see, we'll see how much tooth she's showing, but I'm going to shorten it a little bit, like there. Okay? You happy with that?
Yeah.
And I will like to, the mandible is going to tell me where I'm going to place the maxilla. Am I right? Now keep in mind that I'm going to create an overjet. So I'm going to do the tracing of the mandible now first, because I'm only doing unilateral sagittal split osteotomy. And I don't want to move the mandible further forward in this case. But it's going to be very little, because the midline, I'm moving the midline like 2 millimeters. It's nothing. But let's play it now for our case. I'm going to now watch this tooth here. Can you see this tooth here?
Yes.
I'm going to put my finger on there. That's the condyle. And this mandible is going to auto-rotate. Look. Look, look. I'm going to move it like that. See there?
Mm-hmm.
And now I draw in this part of the mandible. And the coronoid process. And I would draw in that line. And I would draw in this line. So remember I said that we will do this, we're going to do this rather a setback. So I'll operate on the left side of the mandible. And maybe this tooth will go back a touch. So it's there, and maybe it'll go back to there. Okay? So that's the distance that the mandible on the left-hand side will go back.
Johan, how you calculate the distance of setback of incisor when you rotate 4 millimeters to one side?
Because it depends on the length of the depends on the length of the mandible, the size of the mandible.
It's experience.
This is just
you have not mathematics.
Yeah, I suck it out of my thumb.
Yeah, okay.
Because I know it's going to be, it's not going to make a difference if I'm half a millimeter out. Okay, but it tells me in principle where I'm going. Now I'm still going to operate on the chin, so I'm not.
Андрей Николаевич, это вот где революция и опыт. Splint.
So where I can draw in the tooth, that's where I think it's going to be. And I'm going to draw in the molar. About there, huh? All right. Looks like there. Not very clear, but I think that's where the molar is. Okay. And I think the premolars will be there. Okay. And the lowest molar will be there. But now I've got a single jaw case. Now I just stick the maxilla, on top of the mandible. Look like that. Am I right? Mm-hmm. You see there? And there. Now, normally, this patient's got a slight open bite. Am I right? Look. There's a slight open bite. Because there's no overjet there, overbite there. So that is why these lines are parallel. If there wasn't an overbite, then this will be less than there. But it's not significant, but it just explains things to us. So now, here's that thing. I can draw in the maxilla. There's my, that's what's going to happen to the maxilla. I can draw in my tooth. Not sure what the, if I'm right, but I see, this is what I can see from the molars. Okay, now that's where we will be once I've done the upper and lower jaw. Now I need to predict the soft tissue. And soft tissue prediction is usually, you know, in every textbook you'll see, if I move the mandible forward by 5 millimeters, the lip will do that. If I move the chin forward, it'll be 1 to 1 or 1 to 0.9. There's all, but I think every surgeon has his own numbers, because we all work a little, we operate differently, and the soft tissue reactions differently. So in my case, I would now go back to where we were, and you can see, there we go. You see what's happened? The tooth has come, the maxilla has come forward a little bit. See there? Okay. So I can draw in the soft tissue.
Johan, but the mandible incisors move forward too.
No. Yeah, well, because of the auto rotation.
Yeah.
Okay. So we don't want to change this nose, but say it comes forward a little bit. Tomorrow I'll talk about the control of the nose when we do L4-1 osteotomy. Now, can you see the difference, the little bit of movement? It's very little, it's not that much. I would predict something like that. Okay. Now let's go back to the mandible. I'll predict something like that. Now, because I've got control of the chin, I can draw in my chin that I like, my soft tissue. You can see that I haven't done the chin yet, because I'm going to draw in the soft tissue, and then I go back to the hard tissue and see what I need to do. So now here comes the artistic feel that we spoke about this morning. My feeling is now I look at the soft tissue here and I go like this and I draw in the hard tissue. Okay?
Performance finished.
Easy, easy. Does it make sense? Are you happy? You see, okay, now, if I'm not too happy, I could check with my facial contour angle, my SNA, SNB, all those lines, if I'm not sure. If I'm not happy with my chin, I could draw another one in, or I'm not happy with my tooth-lip relationship, I can draw that in. This is the start. The nice thing is, if I'm not happy, I take this, I throw it away. Do another one and another one. And I've done thousands of them that I threw away. I don't like this, I want another one. So it's a nice practice for us. But the nice thing is, when we go to the operating room tomorrow, we have a plan. We know exactly what we need to do. So we will, number one, correct asymmetry. Number two, we'll advance slightly. It's more of it like a little cant, advance. Number three, superior repositioning. Here, unilateral sagittal split. Here, genio. Done. Any questions?
Yeah.
Please, Professor, explain why you use a strongly horizontal line for genioplasty.
Oh, I like that. Tomorrow we're going to have a whole lecture on genioplasty, but it's a good question. If I want to, in fact, I actually thought about it. Instead of doing this, can you see that we shortened the chin there? Instead of doing it with taking this piece of bone out, this one, I could also do it this way by changing the angle of this. So if I advance, the chin will slide up a little bit, and I'll shorten it. Why I did the horizontal is I wasn't sure how much I'm going to advance, because if I'm not going to advance a lot, then I'm not going to shorten it much. Does it make sense what I'm saying? You know, then I can't slide it up. So the angle of the osteotomy and the height of the osteotomy, very important. And tomorrow we're going to talk about it, because the height influences my labiomental fold. That part there. Okay. And also we can widen the chin, we can narrow the chin, we can do lots of things with the chin. We sometimes underestimate the importance of a chin to the aesthetics.
This patient have a very long lower third of the face, and if we apply some others, not strongly horizontal, will be more lower third. Do you think so?
What you say is, if we keep it horizontal, we'll increase the height.
If we keep strongly horizontal, we can minimally change the lower third distance of the face, yeah? But in the fast view, we can show the very long lower third of the face. And I think, maybe I mistake, the strongly horizontal dissection is changed minimally lower third of the face.
We haven't. The only way we can change this patient's vertical, reduce the height, is by further super repositioning the maxilla or further repositioning the chin. That's the only thing we can do. But as I explained, this, I don't want to reduce this too much because now we've got no teeth, you know, she looks like edentulous.
Okay, very
so
good.
So we're a little bit, we have to make a compromise there.
Thank you.
Okay. So we'll see tomorrow when we see the patient what this distance is going to be like. Maybe 3 millimeters, but I'm very scared that we make her look horrible.
Ну, на самом деле здесь получилась вроде как несложная ситуация, но вот как раз разночтение между степенью обнажения резцов из-под губы в покое и выраженная гамме смайл, вопрос, чему следовать, и Йохан, как раз мы вчера с ним на эту тему разговаривали, он акцентирует внимание, что гораздо важнее это покой, потому что гиперактивность мышц может приводить к чересчур большой экспозиции десны. А в покое будет тогда некрасиво, если следовать этому. Поэтому он немножко за счет верхней челюсти, немножко за счет подбородка. И в принципе, ну, я очень рассчитываю, что все будет хорошо.